Hi, my name is Anna Malinow. I'm a retired pediatrician and member of Physicians for National Health Program and National Single Payer. And I'm here to talk with you about direct contracting. Direct contracting was developed by the Center for Medicare and Medicaid Innovation, also known as the CMMI or the Innovation Center, in the waning days of the Trump administration to privatize traditional Medicare. Now, ostensibly, it was created to improve outcomes and decrease costs. Direct contracting inserts a for-profit middleman known as direct contracting entities or DCEs between Medicare and doctors to manage the care for seniors and people with disabilities who have chosen traditional Medicare. Now, decades worth of evidence points against using a multi-billion-dollar industry to save money or improve outcomes for seniors and people with disabilities, but evidence is no match for profit. Now, remember, the total Medicare budget for 2020 was close to $1 trillion. And believe it or not, Medicare is more lucrative for commercial insurers than employer insurance. In fact, 2 times more lucrative. And that's why for-profit DCE middlemen are straight out of Wall Street. They are investor-owned private equity firms, venture capital firms, commercial insurers, and other publicly traded corporations. Now, make no mistake, the goal of the CMMI is to privatize all of Medicare and most of Medicaid by 2030 by handing Medicare and Medicaid to Wall Street. Doctors and physician practices are lured to join these DCEs, and then they fold all their patients into the new DCE. Now, seniors with people with disabilities are being auto-enrolled without their knowledge or consent. It's a bait and switch from a trusted, beloved program. And if they don't want to be in a DCE, sure, they can opt out, but they have to find another doctor. So, Diane?
Yeah, so we're in trouble here because this new innovation, quote unquote, or a social experiment on vulnerable older adults in traditional Medicare is basically poised to turn traditional Medicare into another form of Medicare Advantage. That's the easiest way to think about it. That CMS has literally contracted with a bunch of insurers and private equity groups, as Anna just said, to quote unquote manage care for vulnerable older adults. And that means stepping in between you and your doctor if you're in traditional Medicare. How does it work? As Anna said, if your doctor is part of one of these entities, and these entities are gobbling up doctors left and right because they see the dollar signs, then you will automatically, involuntarily be put into that doctor's DCE. You may not even know it. You'll get something in the mail, but it will look like a lot of the other junk that you get from Medicare. So you may just throw it out. Your doctor may not even tell you that you're in this DCE. And in some ways, it could feel just like you're in traditional Medicare. Here's how. You're still going to your doctor. You still have your Medigap. You still can go to any doctor you want in the country. So that all sounds pretty damn okay. The problem is that now that you have this middleman in the mix that profits every time you don't get care or your care is delayed because it is paid upfront to cover your care, and anything it doesn't spend on your care, it's likely to be able to keep. So anytime you go to that doctor, your doctor may not be the same doctor that you used to go to. And you may not know it. That doctor all of a sudden may not be suggesting you go to some costly specialist because there's something that he or she can't detect about your health care. That doctor may say, come back in a few months and let's see how things are evolving. And you may have no reason not to trust your doctor, but that doctor is being paid in many instances more if that doctor keeps you from getting healthcare services. there are incentives that the the agency, I should say, the direct contracting entity is what it's called, will have for the doctors to keep you from getting care. The doctors may get paid more if you if that doctor is, quote unquote, managing your care and keeping you from going outside of the DCE's network, or keeping you from going to get specialty care, or keeping you from getting more care than you otherwise would get. And that creates this terrible conflict between the doctor's obligation to you as a patient who needs care, and the doctor's incentives from the DCE, the doctor's boss, effectively, to minimize potentially the care that you receive. Anna, do you want to jump in here and say
No,
more?
I think that you've explained it exactly. Is that yes, physician practices are being bought up, and also physicians are being lured by promises of more money, better reimbursement, possibly spending more time with their patients. But these are just promises, and nobody really knows what's going to happen in the end, whether in fact physicians are going to be better reimbursed or even get a chance to spend more time with their patients. So and I think so that's a really nefarious part of the program. But then also that patients, the beneficiaries, the seniors and people with disabilities are being auto-enrolled really without their knowledge or consent. And just as you mentioned, physicians will probably not even tell their patients, and patients might not even know until, in fact, suddenly they find that they are being denied care, or that their care is being delayed, and wondering why it is that the Medicare that they used to know is no longer the same.
Right. And I think what we might find, and this is also nefarious, is physicians either suggesting to you that you drop your Medigap, because that will ensure that you won't be able to go out of network because it will be too costly, or suggesting that you save money by just enrolling in the Medicare Advantage plan connected with the direct contracting entity, because that's the way the direct contracting entity might actually maximize its profits. So just to be very clear, Anna and I have very strong concerns about Medicare Advantage for a number of reasons, not the least of which is that the insurers are profit-making entities for the most part, driven to deliver big returns for their investors, and that's number one for them. And what we've seen from the Office of the Inspector General is widespread and persistent inappropriate delays and denials of care in the Medicare Advantage plan. And with this new CMMI innovation project, we imagine that it's inevitable that the same thing will occur. So what's happened is, for the last 18 months, we've been pushing back pretty hard against this Trump administration initiative. And we thought that we had a shot at least, if not eliminating it, which is what has to happen, at least constraining it significantly. Because as the Trump administration had designed it, as many as 30 million people in traditional Medicare could end up effectively in a Medicare Advantage-like plan in traditional Medicare, or moved into Medicare Advantage once they were auto-assigned, or after they were auto-assigned into one of these direct contracting entities. There are now 99 of these entities, and probably hundreds more chomping at the bit to get in on all the money that's available to them through this program, because, as I mentioned, they get paid upfront a fixed rate for every person who is enrolled in their plan. And so long as they have a disproportionately high number of healthy people in their plan, and the Medicare population is disproportionately healthy, they make money. And so their goal is to have healthy people. And if they're paid the set rate to treat people who are sick, they lose money. So their incentive is going to be to try to drop anybody who is in their plan who needs costly care, or to keep those people from enrolling from the get-go. So we tried very hard from the get-go to have CMS, a Biden administration CMS, limit the number of people who could be part of this experiment, which is supposed to be designed to improve quality without increasing costs, or to lower costs without lowering quality in Medicare. And we were met with a name change from the Biden administration. Effectively, that's what they gave us. They gave us a name change. So the program will be called, as of 2023, REACH, as opposed to direct contracting. But, a rose by any other name, and this is not a rose. This is, a thorn in the side of traditional Medicare, or maybe you could even say a cancer in the gut of traditional Medicare, eating away at its cost-effective system for ensuring that people get the care they need and not discriminating against people based on their health. So now we have the Biden administration's version called REACH, and it still takes away people's choice of traditional Medicare by automatically enrolling them into one of these direct contracting entities. It's still very likely to increase government spending, as Medicare Advantage has done since its inception. It is eating away at the Medicare Trust Fund rapidly. And it's still, if it ends up succeeding, you can imagine, Paul Ryan and others on the right sort of being very happy, because then all they need to do is slash payments to these plans on the traditional Medicare side and the Medicare Advantage side, and say, we can't afford this anymore. And as the net result will be that older people with disabilities will be expected to pay more if they want to get health care. As it is, the typical person with Medicare spends over $6,000 a year out of pocket for their health care. Prepare to see that number go way, way, way up if this REACH program continues. Are there differences between the Biden administration plan and the Trump administration plan? Really pretty minor. We're sorry to say that that there's a lot that's sort of lip service to ensuring that doctors are more in control of people's care, but insurers and private equity have ways to make things look like doctors are in control, but they're the ones who are actually in control, and they're the ones who are, quote unquote, at financial risk, and they're going to be focused on making sure they profit as much as they possibly can. There's also a new piece on health equity. Sounds okay in theory, not even very good. Each plan has to have a health equity plan. What that means, we have no clue. They don't have to deliver on anything for sure. And what we know is, again, because of the way capitation works, and this is a capitated payment system that the government is going to be launching in traditional Medicare, the government overpays for people who are healthy and underpays for people who are sick, meaning that people who are most vulnerable are going to be the people that the entities CMS contracts with are most wanting to avoid caring for. I mean, and that's just inevitable. It's the nature of the beast. We heard one doctor yesterday talk about how even like a doctor's group with good intentions, can't afford, if it's a small group, to have a patient with $1 million worth of healthcare costs. They want to get rid of them. And now you have, for-profit entities without a goal necessarily of making sure people get the best health care. And they're looking as hard as possible at the ways they can maximize profits, which means inevitably giving people less care, delaying their care, giving people poorer quality care because it costs less. So those are all the reasons we are really concerned about this new REACH program and would love your help getting the administration to end it, and making the public as aware as possible about its really potential lethal effects on our healthcare system. Over to you, Anna.
Well, that was great, Diane. I always try to put context into why should I be even concerned about Medicare and Medicare Advantage. I mean, say that I'm a 30-year-old, a 35-year-old, why do I even care what's going on with Medicare? That's so many years away. But the truth of it is that if you are a Medicare for All activist, if this is your passion, if we don't fight this privatization of traditional Medicare, plus what's happening with Medicare Advantage, there won't be any Medicare for All left to fight for. So this is really, really critical for every single activist to get really involved and really care about what's happening to the structure of Medicare right now. So the exciting news is that we are fighting back, and it's making a difference. As Diane said, yes, they are hearing us. Sadly, the only thing that they did is just to change the name, and there's a lot more to do. Now, we have created an anti-DCE coalition, and it's of grassroots organizations. We have several petitions that many of you hopefully have signed, demanding an end to direct contracting entities, that have been signed by over 100,000 individuals. We've met with members of Congress, and as a result, 54 members signed a letter that was authored by Representative Pramila Jayapal to Secretary Becerra, demanding an end to direct contracting entities. And as of March 17th, the Congressional Progressive Caucus, the largest in Congress, sent a list of recommendations for executive actions to the president, which included ending direct contracting entities. So yes, President Biden could end this terrible Trump program and protect millions of people, millions of seniors and people with disabilities with a stroke of a pen. Thank you.
Good morning, everyone. And I want to thank Diane Archer and Dr. Malinow for their great presentation on the REACH program. That is such a dangerous attack on Medicare from private equity and venture capitalists and others who are out there just trying to make a profit off of our healthcare. And you perfectly laid out the policy. And so now it's time for us to let's talk about the organizing, how we can fight this REACH program. So I'm joined here today by a panel of experts who have been fighting to end this program already. And I'm joined by Dr. Ed Weisbart, Dr. Laurel Mark, and medical student Edward Sy. So I'd like each of you to introduce yourself so that the audience knows who they're listening to, and then we can proceed. So Dr. Weisbart.
Hi, yeah, thanks, Susan. I'm Dr. Ed Weisbart. I'm a family physician in St. Louis, Missouri. I chair the Missouri chapter of PNHP, and I'm on the national board.
Okay, Edward.
Hi, my name is Edward. I am a second-year medical student, and I am a proud member of Students for a National Health Program, the student arm of PNHP, and I run the social media of that program as well.
And Dr. Mark?
Hi, I'm Laurel Mark. I'm a recently retired internal medicine doc from Madison, Wisconsin, the co-chair of Wisconsin PNHP. And I'm a longtime member of PNHP fighting for single payer healthcare.
Okay, thank you. And I realized I should have introduced myself first too, as when I started talking, but I am Susan Rogers. I am the current president of Physicians for National Health Program. I am a retired internist. I spent most of my career at Cook County Hospital here in Chicago, and have also worked at the VA and with FQHCs. So I am very aware of the importance of single payer and the danger of this REACH program from my clinical work. So why don't we get started, and I'm curious as to how everybody got involved in this fight. So Dr. Mark, let's start with you. What got you involved in the fight to end REACH?
Well, I have been involved in the struggle to bring a true universal healthcare system to our country for a few decades, unfortunately. And the DCE REACH program is just the latest assault on that effort. I think we truly need a truly universal healthcare program, ideally single payer. The closest thing we have to that right now in this country is actually Medicare, which covers around 80 million people just by virtue of what status they're in. They're over 65, or they have certain specific weird kind of diseases. But this program does allow everyone in the country to know what their benefits are and to go anywhere and have free choice of doctors and hospitals while doing that. It's very popular and people are really familiar with it. We need to expand and improve it. There are definite gaps in it, and those gaps are things that they don't cover, like vision and dental and long-term care and hearing, and the frustrations that some people have about payment. So the DCE REACH program does not address any of the actual problems of Medicare, and it creates a bunch of new ones. So I think it's going in exactly the wrong direction. And it's actually pretty frightening, because if allowed to continue, what it's designed to do is to first of all, put a barrier in between doctors and their patients and the care that we'll be giving. And it will siphon the very needed money away from a program that actually needs some more, and will siphon it to a for-profit entity. None of this is what people on Medicare actually want. So I think it's crucial to us as activists in this space to stop this program in its track. If we're ever going to have true Medicare for all, we better have Medicare for some of us. So that is the main reason that I got involved in this particular fight.
Well, thank you, Dr. Mark. That's a great story of your journey here. Dr. Weisbart?
Thanks. Yeah, it was great hearing that from you, Dr. Mark. So personally, I'm involved in this in part because I have Medicare. It's my health insurance, and I've had lots of other types of health insurance, and I'm here to tell you I love having Medicare. I have traditional Medicare. I spent a long time, all of my working career, paying in advance so that I could have it. And all those years when I was frustrated with the problems of commercial employer-based insurance, I was eagerly anticipating how much better it would be when I would finally get into Medicare. And now here I am 3 years in. And then what do I learn a few months ago? But that somehow the program that I've been looking forward to is under direct attack. And so this is personal. I don't want that done to me. I don't want it taken away from me. I feel like I've earned the right to Medicare. I frankly feel like everyone in the country has earned the right to have Medicare, or is, just by living here. So as Dr. Mark said, we need everybody to have it. I'm perfectly fine with the fact that Medicare is a tax-based program. I think that's how you should fund public goods. And I'm fine with paying taxes for that in a fair and equitable way. But it's making me sick to look at my tax dollars that I pay into Medicare being diverted away from healthcare and into Wall Street profiteering. So that this DCE REACH program is taking my money and your money and giving it to people who, that's fine, live long and prosper out there, but don't come after my stuff. Don't take Medicare. We all need that. And then the other piece about it that got me into this DCE REACH fight is realizing that it's below the fold in the newspaper. Nobody knows about it. It's below the radar. Most people in Congress who should be responsible for protecting our most cherished public health program had never heard of it. And so, when we learned about it in PNHP and realized that even Congress didn't know about it, we thought, goodness, we've got to get to work on at least protecting Medicare. And, no matter what you think about Medicare for all, you hopefully agree that we need to protect Medicare. And as Dr. Mark said, if we let Medicare get eroded and corroded, well, then what do we have to fight for? We have a much more difficult challenge. So this is a really critical fight.
Okay, thank you, Dr. Weisbart. That's so true. And as a traditional Medicare recipient too, and concerned not just for the whole country too, but Edward.
Yeah, so quite simply, a lot of the same reasons. I am a medical student and a future physician, and as such, I obviously want to see my patients healthy, and I don't want to see my patients get healthy, at the cost of, going bankrupt, right? So, as you two are part of Medicare, and so is my grandparents, and soon my parents, and them as well as my future patients. I don't want to see them, get their care skimped on, just so some CEO can make, a lot of money, right? And obviously, when I become a doctor myself, I do not want to be a part of that conflict of interest of me being incentivized to skimp on my patient's care because, I want to make more money, or some person in my firms, wants to make more money. I just find that to be completely unethical conflict of interest, and I don't want any part of it. In addition, I'm a member of Students for a National Health Program, which means I advocate for a single payer system. I think a single payer system is efficient, it's effective, it's and it's universal. And yeah, what people don't know, and I'm reiterating what Dr. Mark said, is that indeed traditional Medicare, not Medicare Advantage and all that, but traditional Medicare is indeed a single payer system. And it's, we need to preserve that as a shining example that indeed a single payer system can indeed exist, and not only exist, but thrive in this country, because like people have been saying, Medicare is a popular program. It is beloved. And if anything, we have to keep it that way.
Okay, thank you, Ed. And I know that this affects you personally too, through your grandparents, and hoping that they and the future patients that you'll see. Just a few words on why I got involved here. When I've known about the single payer movement for many years, and through my training at Cook County Hospital, which was kind of similar to a single payer system in that I never asked a patient what their insurance was. I never asked if they could afford this medicine. It was all provided through the Cook County system there. And so I was able to provide for patients what they needed without the distraction of financing and whether they could afford it. And what has happened over time is that we now have this new threat, even with traditional Medicare, which functions well, it does need to be improved. And rather than focusing on improving that, they are trying to privatize what we currently have. And we can't minimize that threat, the threat of privatization. And what it is its underlying momentum comes from this, I think, a naive belief that providing for public good is better done through the private sector. And I think we all know firsthand that that is absolutely the last thing that's true with providing healthcare. Providing through the public sector, private sector does not improve healthcare. It's a distraction from providing healthcare because its primary motive is to make money. And so we have to fight this. And I think that it is crucial if we are ever going to attain single payer in this country, that we minimize and totally eliminate the threat of private insurance having a role and profit as a motive in providing healthcare. And I think it's important that we don't allow physicians to be put in the middle of decisions that are made where they are pressured by their employers who are trying to make money while they're looking at a patient who was in need that they may not be able to fill because of that outside pressure. So let's talk about the strategy, the outside strategy of how to get people involved and educated. Dr. Mark, how do you go about informing allied groups about this issue in your area?
Well, I think the reason that I'm on this panel is because that has been our focus as a chapter really ever since we were alerted to this problem back in the fall of 2021. So if you give me a minute or so, what I want to do is outline for you what we have done and what our plans are for the future. And I think that's a guide. The first thing we did was educate ourselves. This is a really complicated program. And honestly, I had to go through that information several times before I understood what this was all about. And I think that's part of the problem, is that this is why one of the reasons it is difficult to organize on it, because you have to understand what it is, and it's all in the weeds and it's all below the radar. So that's the first thing. There are wonderful resources right now online, thankfully, thanks to PNHP mostly and other groups. So you can do that. So the first thing is educate yourself and then educate the group. So at our monthly meetings, every month for the past few months, we have devoted either part or most of the time to teaching each other about this, the program and where it stands. We distributed a lot of information by email to our statewide group. Everyone has, and we asked people to send them out to their own networks of colleagues and friends, since this involves everybody just about in the country. And we posted things on Facebook and on Twitter and posted the petition multiple times, had action calls for people to do something, and just kept reminding them of that. What we have found is that over the past few months, the numbers of views for all of these, both email, Facebook, Twitter, have gone way up as this program has become a little better known. So we did community outreach on social media by regularly posting things multiple times every few weeks. We offered people the opportunity to sign on to the petition, both as organizations and as individuals. And then we started doing some presentations virtually this year to interested groups about this, and have set up some radio interviews around the state as well. We did some specific outreach to, we targeted healthcare advocacy and research organizations here in the state. Wisconsin happens to have a fairly robust number of these that are people who are really deeply knowledgeable about their area in healthcare. And there's a group called Wisconsin Health Matters, which is an umbrella group of these organizations that meets every other week, this year by Zoom. We were able to coordinate a meeting inviting Dr. Malinow to come and present this program to these extremely knowledgeable people, none of whom were aware that this was happening, as Ed said. And that was a really successful outreach because it really allowed us to talk to people all over the state who care about healthcare in different areas. And we got some organizations that were willing to sign on, but certainly more information around the state. And also hookups with other community groups throughout the state through that group. And we are continuing, we are a member of that organization. We continue to meet with them and update them on what's happening. We are also, Wisconsin PNHP is the lead organization in Wisconsin, the Wisconsin Universal Healthcare Coalition, and we distributed things with that as well. And then we contacted our representatives. We contacted the congressional representatives and the one US Senator we have who is interested in expanding healthcare and helping us out with healthcare, and have had meetings with their legislative aides, provided the information online to them, involved medical students from our Students for a National Health Program chapter in those Zoom meetings, involved some community activists in other parts of the state, so we weren't just in one place. And had a direct ask for them to be leaders in Congress on stopping this program. We've also asked, and we have for direct meetings with the representatives and senators. Some of those are set up. And we follow up with thank you notes. Email is just fine for that. And follow up with the legislative aides. And then we have a plan to go forward and talk to senior groups and disability groups and community groups, because as we all know, we're all going to be affected by this and nobody knows that it's happening. So that's what we did.
Thank you, Dr. Mark. It sounds like you've been very busy in Wisconsin, and I'm sure that you wouldn't mind if people reached out to you to get help to help organize their own entities in their state or chapter, so that they can initiate or improve on the work that they're already doing. Now, Dr. Weisbart, I know you've done many talks to both national and local groups about REACH. And what are the strategies that you use when talking to others about REACH?
Yeah, the underlying theme in my mind is to simplify the message. Simplify, simplify, simplify. This is, as Dr. Marks said, this is a really potentially very complicated, deep in the weeds topic, but you kind of have to get into that if you want to do a really good understanding. But I think Dr. Rodders, you did a great job at the beginning, and I think Dr. Malinow and earlier we heard really a good discussion of keeping it at a nice high level too. So the first tip is to really gotta simplify it. And when the reason I say that is kind of think back to when you first heard about it, and it was overwhelming almost. And so starting, the best way to learn is by successive approximations, by gradually learning more and more about something. So start at a high level. Remember how it was when you first heard about it, and you probably thought this was crazy. You probably were in a denial phase because it's like, no, that can't be happening. So try to keep it simple. Try to know that you're going to sound hyperbolic by raising this issue. And so that's the first tip, is using something like PNHP's slide deck, or if you're not going to use the slides, talk with that story arc. Because I think, PNHP staff, Claire, did a fantastic job at thinking through a narrative that emerges and builds. So the first tip I would have is to make it as simple as you can. Not my strong suit usually, but that's my first tip. The second is to make it personal. So, when you asked me, how I got involved, I went straight to as personal as I can get, me. But you may not always want to do that. And so I have family stories I can tell. I have a mother-in-law whose healthcare would have been sorely compromised if she had been forced to stay in a network like Medicare Advantage. She doesn't have that. She has traditional Medicare. Or if the DCEs had gained hold over her healthcare, she probably wouldn't have been able to travel outside of where she wanted to go for the best care for her condition. So a story like that, or a story, if I'm talking to a senior group, they understand how important that is. I'm talking to a younger group, stories of other folks. I have people who are much younger, a story, making it personal helps. And then, maybe try asking, are you just sick and tired of having an insurance company get in the way of your healthcare? Everybody will raise their hand, just about, and somewhere in their mind, they're probably thinking, but when I get into Medicare, if it's still there, please don't let it go away. If I get into Medicare, if it's still there, then they won't be in my way. So the second tip is try to make it personal to the people you're talking to, tailor your message to exactly the group you're speaking to. And then lastly, trying to make it real, because as I said, it sounds unreal. This program it's hard to believe that something this robust, this dangerous is happening. Of course, now we have other dangerous things happening in the world too, but it's hard to believe that this is happening to Medicare. And so to sort of disarm the disbelief, use some of the external validations, talk about the 54 representatives that have signed the letter, talk about the lots of external validating points that we have, showing that it's that we're right at the top of the list of the Democratic calls for executive action. This came out. Explain how this can be happening without Congress's involvement because of what the Medicare Innovation Center is. And then, they have that power. Yes, and not only do they have that power, but a guy who was Jared Kushner's roommate became the head of the Medicare Innovation Center and then created this program to favor his previous company that he left from. So stories like that. So my tips are simplify it, make it personal, and make it real.
That's such a good point, Dr. Weisbart, because healthcare, no matter how minimal or serious the issue is personally, it's still very personal to you. And I think that it's important that people understand that even if you don't think that this may affect them directly, it's affecting somebody that they really care about directly. And personalizing it is a good skill to develop, being able to do that well. Ed?
Yeah, so, if you're a medical student like me, who values people over profit, then I believe this is something that, we should be working on. It's important that we work on this. So, like Dr. Weisbart has said, number one is education, really. I think healthcare policy, law and law and policy are usually very opaque and complex. So it's very important to sort of break it down and simplify it, so people can more easily grasp it. And then what you can do is sort of organize presentations among your medical students or whatever organization you're a part of, like residents or doctors as well. And then also, so PNHP has many resources that can help you along that way. It's important that you first understand it, and then you go along and try to indeed also educate your fellow students. And in addition to education is, in conjunction with education is also spreading the message. A lot of medical students are on social media and they've been doing great at sort of retweeting and sharing the stuff. I'm part of the social media, so I would know that social media is very important for any activist organization, and I myself and another student have been sort of posting on social media. We've been doing a good job at distributing that information as well. And lastly, I think it's important to contact your legislators. I know for me it was very intimidating at first, but it's important to find that inner voice, that inner sort of that passion to really build your resolve to practice your right to petition the government, really. And you got to understand that it is the job of the representative to listen to their constituents, and that's very important as well. One thing that's important is that it's important to have a voice, because I can assure you that our opponents are talking to them, are trying to influence our politicians, and if you stay quiet, then that's a huge problem, right? Because they'll just be listening to them. They'll think, oh, everything's all right. Just one more note is that I'm really proud of all the work put in by students in SNAP. It was the students who, for example, almost got the AMA to drop their anti-single payer language. I believe last year in Pennsylvania, in their medical society, it was a student-led effort to drop their anti-single payer language as well. And I've seen many students write letters to their newspapers, which is great. So continue doing that.
Can I underscore something you just said, Edward? Because I think it's so important. You said that you promised that our opponents are speaking to legislators, and I think that's so incredibly true. And when we go and talk as one person talking to one legislator, it feels like, is there a point to this? Or when we send a note, is there a point to this? And I'm here to tell you, every legislator I've spoken to, when they almost always say, well, we're hearing from your opposition and we're not hearing much from you, from your side, or they say the opposite. They say, yeah, we're hearing a lot of this. Or when they go to the legislative floor, they'll say, I'm getting deluged with comments from my such and such, so it's, is one person going to persuade a legislator to change their position? Maybe yes, maybe no, but your voice as one of many becomes really important. An example that came home to me last week was I have in our state house, in our state legislature here, I have the pleasure of being represented by a really good progressive in a really conservative state. So I'm just really happy about that. And when I get these requests to send her, one of these emails or one of these notes, or call her and say, please support such and such, I feel like I'm wasting her time because I know what she thinks. She's already in agreement with me. So I actually last week said to her, I'm getting these requests to reach out to you, and I tend not to do that because I know, you're already in my camp. And she said, no, it doesn't take any time. And it really empowers me when I'm on the House floor to be able to say, look at all the notes I'm getting, look at all the commentary I'm getting. So even the people that we agree with, you're not wasting your time with them, you're further arming them. So what you said, I think, is really important, Edward.
They're great points that you reiterated, Dr. Weisbart and Edward. I think that your activism and your energy is just phenomenal as a student doing that. And I do want to point out to those listening to this webinar is that when Edward tried to start his SNAP chapter there at school, he was denied in Virginia by the school. And they really didn't have a good reason other than they were, I guess, single payer opponents. But Edward got a lawyer and attempted to sue the school. And I know clearly that was out of your comfort zone. That was not in your area of expertise, but it was successful. So I want to point that out because sometimes as activists, and especially grassroots activists, we have to get out of our comfort zone. And we have to talk to people we may not be totally comfortable with. We have to talk about issues that we know may create an argument or disagreement, but that's part of getting out of our comfort zone that gets us to the goal that we are all trying to reach. And the other thing I'd like to point out about with students is that one of the important reasons I think for students to be so involved is that by preserving traditional Medicare and getting private health insurance companies, private equity firms, venture capital, all these profit-making entities out of healthcare, we have to get them out to help preserve the doctor-patient relationship. Because right now, that's the biggest threat to you as students, is not being able to be the kind of doctor that you went to school to become. And I've never personally been in a situation where I had a conflict of interest in terms of what I had to do to keep my job and what I had to do that was best for the patient. And that's becoming the norm now. And so I think that if we want to preserve healthcare in any kind of way that promotes healthcare for the patient and for their benefit, we have to eliminate this private entity that's getting involved and just being having a presence in the exam room with physicians. So I don't want to take all the time, but Dr. Mark, can you mention a little bit too about the follow-up that you've done as you continue doing your outreach and working with other groups and making meetings, and how you kind of got the different entities together to work?
Yeah, follow-up is very important. You have to think about this both with outreach to community groups and to elected officials as relationship building. So generally, it's not a one-time affair. It's usually the situation where you're going to be talking about an issue that has different nuances. And so in the future, there will be other versions and other things you want to talk about, and you want to know who you're talking to. So it does really help to have some administrative help, or to have, we are a volunteer organization mostly. PNHP is mostly physicians, and a large part of the membership are people in current practice. And there's not a lot of time left over to do any of this, and certainly not a lot to do administration. So it does help in any group to have somebody or some group of people who will devote some time to that, and just keep track of it and not just have it be one person. It helps to know who it is you're talking to. You're actually talking to a person when you call anybody's office or when you meet with a group, and to know ahead of, to try to like understand like who they are and what their role is and how you follow up. So we always start our meetings with a little bit of personal conversation, and then ask directly how we are going to follow up with them, and then make a plan to do that. We have invited people into coalition with us, and even when they don't come, they get all of our emails, and some of them have responded to the ask on this one, even though they don't come to the meetings. I think it's really important to thank people. People like being thanked, and they like being invited. So just do that directly. If you have had a conversation with somebody and they need more information, it's a really good idea right at the time or immediately after to just send that information on. I know from my personal experience, if I don't do it right away, it gets to the bottom of the pile. It doesn't always get done, but it does reinforce what you're talking about. And then I try to make a plan where after the thank you, like a week or two later, we send a follow-up email or follow-up phone call, however we are reaching these people, and keep working on it. And for groups that we're working in an ongoing way, like some of our groups in northern and western Wisconsin, we have actual meetings. Before a meeting will end, we'll set up the next meeting. It might just be a quick 15 minutes, Zoom call just to check in and see where we're at. But by setting it up, it actually happens. It helps to have someone who's really organized and who can be an administrator if it's possible.
Those are great points, Dr. Mark. And I think that one of the really important ones that you mentioned was to do the follow-up right away, because we do end up putting things off, and then it gets lost in the deluge of emails and messages and all of that. So it's important to follow up so that the people you want to engage don't feel that you've forgotten them. But they're great ideas. And the thing about the administrative help too, I know with PNHP, that the office here in Chicago is vital to all that we're doing for direct contract entities and the work involved in that. Dr. Weisbart, how do you recruit individuals to get involved with this?
It's probably through a lot of what we've just been talking about. It's a topic that people don't know exists, and so it's kind of easy to bring it up. But the trick when you bring it up as a topic is that it, like as I said a little bit earlier, it sounds like you're crazy if you're not careful. It sounds, if they haven't read about it anywhere, if there's been no external validation, and you're talking about this different topic, that it's pretty easy for it to just be, it's pretty hard for people to believe it. So, we are fortunate, now compared to a few months ago, that we have these external validators that I mentioned some of, and you can point people to Bloomberg News has been covering it, and it's to the groups that you don't think of as being leaning towards our direction. And then the other thing that I think is something helpful is to think about, as Dr. Mark was saying, think about the people to whom you're speaking, and think about what other issues perhaps are on their plate. And for those of us in this part of the advocacy world, healthcare is, of course, really high on our list, and not for everybody until they see the connections. But what you can do is draw the parallels. In rural farming communities, for example, there's a lot of resistance to the idea of corporate takeover of the seed process, and lots of things that farmers are concerned about. And they know far more than I do about the impact of corporatization on their ability to have their family farm survive. And so this, is a direct parallel to that. Drinking water, corporate takeover of drinking water in Flint, is schools, the corporate takeover of schools. There's groups have different issues that are their passion, and they often know those issues deeply enough to recognize the structural issue, the corporate attack on democracy, frankly, and hadn't maybe drawn the line connecting to, oh, that's what you're talking about is the exact same thing that I've been fighting against in my focus area, and I hadn't realized it was happening here. And so it's, number one, it's good to connect the dots, and number two, to point out that as rapidly as DCE and REACH is growing, it's still small enough, we think. We don't really have the numbers and how big it is, but we think it's still at the point where we can stop it. we can, as the Democratic caucus did today, well, or a few days ago, we can actually ask for an executive action to end this program. That would be pretty tough to do with some of the other things that you can't have an executive action that ends climate change, but you can have an executive action that ends this particular program. So I think getting a win, focusing on the fact that we're all focused on these big long-term issues that we want to make short-term. This is one that's really inherently, potentially a very short-term win. And my gosh, don't we all want to get some nice short-term wins that are really not just lip service, but substantive and meaningful. So I think those kinds of things help people want to get engaged and take this on.
Yeah, that's a good point, Dr. Weisbart, about the short-term wins, and especially if we look ahead at our goal of getting single payer. Any kind of short-term win against the REACH project will help us get to single payer, because if this REACH project progresses, it's going to be more and more difficult to get to single payer, which would have no privatization, which we all know. I do want to not run over our time, but one of the things I want to ask you, Edward, is when you set a meeting, why is it so important to determine what the ask is when you set that meeting up, so you don't get distracted and you can focus on what you want to meet about?
So when you go talk to a congressional aide or a congressman, it's important to come into the meeting with a purpose, right? So when we talk to Liz Fowler, who is the CMMI director, and she has quite a reputation of taking like government jobs and then private sector jobs and then switching back and forth. But anyways, I talked about how seniors might be taken advantage of. I talked about how I might be incentivized, or how doctors will be incentivized to skimp on care. And then I sort of just stopped and said, I just asked, will you, or are you willing to shut down DCEs? And quite frankly, obviously, she wasn't going to say, oh yeah, sure, like, yeah, I'm going to do that right here, right now, but what I'm trying to say is that it's important to come into these meetings, with a purpose, and to get that purpose known. Otherwise, she'll walk out of the meeting, not, like, having no idea why we were there. She might be thinking, oh, were we just there to vent or ask questions or to complain? And then she might be like, oh, okay, if that was it, then maybe, we can just tweak it a little bit to satisfy this group. But, it's important that you ask, and what that ask is not just, a little tweak, is indeed the full shutdown of this, disgusting, insidious program. We also talked to some other representatives as well, and the things we were asking were, if they were willing to sign on to that Jayapal letter that we sent. You can ask for things like if they're willing to support the opposition to DCEs. We asked if they were willing to support congressional hearings. And so what I'm trying to say is that, it's important to come in with a purpose and to sort of try to get something out of it. And obviously it's good that, to maintain good relations with your congressman as well.
Yeah, those are very good points, Edward. One of the things that I have learned is the necessity of an agenda, and that you have to come in with an ask. Otherwise, you just sit and talk for 15 or 20 minutes or however long you wanted your meeting to be, but you don't end up with any sort of resolution or endpoint because the conversation wasn't focused. So I think that's a really good point, that you have to have your ask determined when you set up the meeting so that people aren't surprised, and the meeting is focused and not just a chance to talk about something without any kind of endpoint. Well, let's let's just talk about what our next step should be. And if I'll ask each of you, if you have to prepare a call to action to your support groups, what would that call to action be? Dr. Mark, I'll start with you.
I think it's very important that people get to know about this program. The reason it has gone as far as it has, it's actually in an implementation phase right now. And as a pilot program, it involves too many people. It does not look like a pilot. And by their own words, they are planning on expanding it to all of traditional Medicare. So this is not just some simple little pilot program in the side that we can ignore. This is for real threat. And the fact that people don't even know about it is one of the reasons it can go forward. So it's really important to be out there and make sure that community groups, even not ones that are particularly focused on healthcare, know about it. So I would say, again, educate yourself in your group, get prepared, do all those things that Dr. Weisbart mentioned to you about being ready to talk about this, and start educating people. Again, with an ask to a group would be to call their representatives, I think they should call the US Senate as well, even though they're in a different house. Congress is, and the White House is where this is going to get shut down. And just like Ed said, if your representatives who you think agree with you never hear about it, they don't have a leg to stand on. And that's what we have been told as well. So educate yourself, educate your group, choose some community organizations to deal with, make sure they understand what we're asking them to do. And that petition is easy to sign right now. And then follow up with them. Set up a meeting by Zoom or something a week or so after your meeting, and know what else we can do to go forward.
Great suggestions, Dr. Mark. Dr. Weisbart?
Yeah, I would echo what you said, and I'd say, the best place to learn more. So I have 4 things I ask people. The first is to learn more, and because you have to, if you want to speak to others, you have to feel internally like you really personally understand it. And the best place to learn more, I'm so proud to say, is at pnhp.org. Our staff has done just an amazing job of doing the stuff we need to do. So you can both learn a high-level summary there, and you can go as far down into the weeds as you want. And the information is there, accessible at any one of those levels. So the first thing is to learn more yourself. I say that to everybody in the group that I'm speaking to. And then the second thing to everybody in the group is we have an individual petition. You can raise your voice on this. You can sign it right now today. If you have your iPhone or your cell phone with you, here, pick up your phone. Here's the address. Go there right now. Go to pnhp.org right now. And within 5 seconds or so of you being at that website on your phone, the first thing that'll splash up is sign our petition. So if you feel like you already know enough, go right now and take that action right now. But if you want to learn more, certainly learn more, and then individually, everybody in this room individually sign that petition. And it's powerful to have a lot of people on that. We have thousands, and we need thousands more. And then the third ask is to have your organization sign up. So if you're speaking to a group that is an organization, sign up, have your organization sign the organizational letter. And people will think, well, it's a little organization. It's just the Boise chapter, not to pick on Boise. It's just the local chapter, but if you look at the 250 or so as of today, organizations that have signed on against this, it's a broad range of organizations, from national organizations down to little organizations. And the importance of that is that when we speak to legislators and say, hey, look at the organizations against it, understand it's covering the entire country. It's covering demographic. It's going deep into society. It's this local chapter of the such and such organization. That's powerful that we have such depth. So even if you're in a small chapter of some group, sign it, have your organization sign it, and think of the other groups you're part of and have them get engaged in the same way. And then the last thing is what, Edward and Laurel were talking about, of, calling your electeds and or visiting your electeds. And if you do get them, do what Edward does, and interrupt yourself and say, okay, yes or no, are you going to go with me on this? And if you get to a yes, that they're going to agree with you, the next question is, can I quote you? Can I quote you? Because you don't actually want to break the confidence and quote them if they don't agree to that. And if they won't let you quote, if they won't let you quote them, ask them, well, why not? How can I trust your answer if I can't quote you? So you should be able to get to a quote if they say that. So learn more, sign the petition individually, have your organization sign it, and reach out to your elected officials.
Great. Thank you, Dr. Weisbart. Edward, did you have any?
Yeah, before I say like what we should be doing, I just want to reiterate that I believe Medicare, or this REACH program, will potentially do some irreversible harm to Medicare. And it's, by the time we see the damage, it might already be too late. And, just, for example, just imagine, our beloved Medicare program, being corrupted into private for-profit, dumpster fire that we have right now for people who aren't on government-funded healthcare. And, just have that in mind. And then from there on, it's important to do what Dr. Mark has been saying and Dr. Weisbart has been saying. Talk to your legislator. They don't bite. And PNHP, we have scripts for you to help you out. And I'm sure if you ask us, we can help you out with that. And also, like I said before, it's important that we spread the word as far as you can, whether that be as simple as retweeting something or making a post, or indeed planning presentations with your group. It's important to keep the word out. And using these grassroots methods, I think PNHP has done a great job, an amazing job. We've had, like we said, we've had over 50 representatives sign on. That's all because of what we've been doing, all the hard work that PNHP has been doing. And in addition to that, we've had significant media coverage. And I just want to say, we have been putting a lot of hard work into it, and it's important that we keep the momentum going. So thank you.
Thank you. And I want to thank our panelists so much for joining us today and sharing their experiences, their wisdom, all the tips and suggestions for working with other groups. And I think too, it's important to remember each group is different. So sometimes we have to tailor our ask to different groups. How you approach a group of 30 somethings is different than your approach to a group who was already on Medicare. So, but everybody has a role in this fight. And we just have to define that role of the groups that we reach out to help them, to help guide them, and to help us reach the endpoint, which ultimately will be single payer Medicare for all. Okay, thank you so much, everyone, for joining today.